this week on the BackTable podcast.
But it really is about the stone burden. So, for instance, I always warn patients, if I'm seeing a patient with cystinuria and they've got, 3 small stones in one kidney and 2 small stones in another kidney, I say, you've got 5 stones that could potentially pass. That doesn't mean that if those stones pass, that doesn't mean that we're doing a bad job with our prevention strategy. Those stones aren't my fault. If you form new stones or those stones get bigger, that's my fault, and that means we need to reassess and get more aggressive with our prevention strategy.
Hello everyone, and welcome back to BackTable Urology Podcast, your source for all things urology. You can find all previous episodes of our podcast on iTunes, Spotify, and BackTable.com. It is Jose Silva as your host this week. I have to introduce our guest, Dr. David Sass. Dr. Sass has a doctorate in osteopathic medicine from Arizona College of Osteopathic Medicine, then went on for pediatric residency at Innova Fairfax Hospital for Children. After this, he did a fellowship in pediatric nephrology at UT Southwestern. He studies pediatric kidney stones. His research involves children with idiopathic kidney stones disease, as well as children with very rare disorders like primary hyperoxaluria, dent disease, and cystinuria. Currently, he's an associate professor and chief of pediatric nephrology and hypertension in Mayo Clinic-Rochester. David, welcome to BackTable.
Thank you for having me. It's an honor to be here.
So today we're going to talk about kidney stones in the pediatric population. Like I mentioned, David, you are a nephrologist. So let's start talking about your practice. I know you do research. So how much is research versus clinical in your practice?
So I'm about 60% clinical, and the remainder is some mixture of administration and research. I also help direct our renal lab here at Mayo Clinic.
And in terms of the patient population, do they fly all over the states to see you? Is it mainly referral from other nephrologists? How do they find the kidney specialists?
Yeah, so about probably 75-80% of my patient population is kids with stones, and they do come from all over the country, all over the world. I think that's, just a byproduct of being at Mayo Clinic. The surrounding population in Rochester, Minnesota is not that huge, so we do rely on a lot of doing second and third and even fourth opinions sometimes. So we see kids from all different backgrounds.
So mainly, you usually see the complicated cases. You're not going to see a patient that just passed a kidney stone.
Correct. I do see that as well. Kidney stones, unfortunately, in children, the incidence is high enough that we do see them from the local general population and the rest of the state and region. So I do see some sort of run-of-the-mill pediatric stone disease, but then also the more complicated rare stone disorders.
And at Mayo, do you have like a stone center? Is a combination with urologists? Are your dietitian involved?
Yeah, so, a lot of places do have the so-called stone clinics where all those players that you just mentioned are involved. We talked about setting one up there like they have at some other places, but honestly, I've got my pediatric urologist and adult urologists who specialize in stones who are available whenever I need them, but not every kid needs to see the urologist at every visit with me. In fact, I would say if I'm doing my job, they shouldn't be seeing the urologist, but if needed, my urology team is there to address any acute situations, or if I need them to review imaging to say, hey, this kid's stone burden is increasing. Do you think there's a role for intervention at this time? So we have open communication, but we don't necessarily have a stone clinic together. And then as far as the dietitian, I prefer to manage the dietary aspects of stone prevention myself. I have a master's in public health where my focus was in nutrition, so I have some formal training in that area, and I really enjoy doing it. And Mayo is kind enough to provide me with the time during my clinic visits so that I have time to adequately address that. So I really enjoy doing that part all myself.
Excellent. So we'll definitely talk about nutrition later today. So let's start just a general overview about the clinical presentation of pediatric stones. Is it more or less the same as an adult urologist, where the patient goes through the ER with pain, or do you see a different part in, for example, the painless hematuria?
Yeah, so for sure, the kids can present in the classic adult fashion, with unilateral back or flank pain and probably some microscopic hematuria or gross hematuria and nausea and vomiting. But the younger you get, the more atypical the presentation can be. Sometimes it can just be abdominal pain and often mistaken for appendicitis, or I shouldn't say mistaken, but their ER physician's differential diagnosis is appendicitis, and they look for appendicitis and find a stone instead. So there is variable presentation, as you alluded to, and then also the incidental findings. So for sure, kids who are being evaluated for hematuria, we do a renal ultrasound, and lo and behold, we find stones. That can certainly happen. So I would say it's a little bit less of that classic presentation that you see in adult urology and a little bit more variety in how they present in pediatrics. And in terms of the mechanism of their presentation, it is often, as you described, after they've been to the emergency department. Very frequently, I'll get an email message or an inbox from my urology colleagues who will say, hey, ER called me about this kid. I put a stent in him. We're going to remove the stone. But just so you know, I set him up for a clinic visit with you in a few weeks. So that's probably the most typical presentation that I get.
So I was going to ask about that. So is it normal to have stones in children? I mean, in the sense that, will you do a metabolic workup with any patient with a kidney stone?
Yeah, so stones in children are not as common as in adults, but it's becoming more and more common. I think a few decades ago, if you told an ER physician or a family physician or even a pediatrician that you had a child and you said, hey, I suspect kidney stones, they would say, what? Children don't get kidney stones. But turns out they do, and we're seeing it more and more frequently. The reason for this rising incidence is speculative at this point. We don't really know. I have my own thoughts on what could be doing it. But the point is, it's still rare enough that I think every kid who is found to have stones deserves a true metabolic workup, including blood work, a 24-hour urine. And I also believe that there's a role for genetic testing. And that's a controversial view. Some people would say, no, you shouldn't do genetic testing in every kid with stones. That's a waste of resources. But I think it's worth doing it, especially the younger the child is. So the younger the child is presenting with stones, the more likely you are to find a genetic cause for their stone disease. And we haven't published this data yet, but we're getting close. We've been doing genetic testing for a number of years now, and we enroll. So part of our inclusion criteria is any child, any kid under the age of 18 who presents with a stone. And we're getting a resolution rate of about 30% where we're finding a genetic contributor to their stone disease, acknowledging, of course, that this is the stone clinic phenomenon and the fact that we're Mayo Clinic. And so our yield is going to be higher than the general population. But still, 30% is pretty high.
And are you aware in those patients that do have a genetic component, do their parents have it, or is it just the combination of the genetics that makes them more susceptible to forming stones?
Yeah, so the nice feature of our research protocol for genetic testing is that we test as many family members as we can get samples on. So almost always a sample from the parents too, to help us segregate it out and determine whether we're seeing an autosomal recessive phenomenon or autosomal dominant. And so getting samples from parents is very important, and also siblings, whether they're stone formers or not, because again, that helps us determine the likelihood that gene is contributing to the phenotype. So yeah, we will often, figure out which gene came from which parent that way. And that's helpful for parents deciding about, future pregnancies, and for us to help, monitor any siblings who might develop symptoms or, importantly, might remain asymptomatic. Because one thing that's interesting about stone disease as a disease process that we study clinically and from a research standpoint is that patients really care about stone passage events, and urologists really care about stone passage events because that's what lands you in the ER with 10 out of 10 pain. But stone passage does not reflect disease severity. I mean, of course, to some degree it does, right? If you're passing 10 stones a year, that's horrible compared to passing one stone every 5 years. But in terms of the stone burden causing chronic kidney disease down the road or hypertension, really the stone burden on imaging is what I really focus on, because it's the passage of a stone is an unpredictable and arbitrary event, right? But you can have kidneys full of stones that are completely asymptomatic. So that's something that I really focus on, is the stone burden. And when we look at siblings, we often find disease that is silent but equally as severe. We published a paper a few years ago in our cohort of patients with a rare kidney stone disease called primary hyperoxaluria. And what we found was that patients who were identified through family screening had just as severe, if not more severe disease in terms of their stone burden and oxalate burden than those who were identified purely through clinical evaluation.
And you mentioned the function of the kidney and or severity in terms of renal function. Do you do renal scan, for example, in this population to see if the kidney is affected?
Yeah, so as part of my basic workup, they'll all get a basic metabolic panel, that includes BUN and creatinine, as well as we do a lot of cystatin C here. So, cystatin C is shown to be a better way to estimate GFR. So because I've got it available in-house with a turnaround time of, an hour and a half, I do it in all my patients to better estimate their GFR. So, most of them will have intact GFR, but not always. And that's another important indicator. If you see any decline or any diminished GFR, that strongly suggests that there's going to be a genetic component. And it also tells you need to be pretty aggressive about your prevention strategy because, you especially in a child, you need that kidney function for your entire life. So you certainly don't want it to be diminishing early on in life.
Exactly, because I contrast that to for an adult that sometimes we do conservative management for those stones that are asymptomatic but definitely if the patient is asymptomatic, doesn't mean that there might be still some damage to the kidney.
Yeah, exactly. And, again, same thing in our adult side. So our genetic testing protocol, we've also been doing it in adults. And for the adults, the inclusion criteria are a little more strict. It's not just any adult with a stone, but there have to be other reasons why you would have a suspicion for a genetic cause. And so for those, it's the recurrent stone formers or those with a family history or those with nephrocalcinosis. Nephrocalcinosis seems to be a predictor for a genetic component to their disease and also progression of CKD.
So going back to that workup, that metabolic workup, also, what else do you do? Do you do a 24-hour collection for those patients?
Yeah, so generally I'll do the blood work I mentioned, the BMP and the cystatin C. I also look at a few other things related to mineral metabolism, including phosphorus, magnesium, parathyroid hormone or PTH. I look at 25 vitamin D as well as 125 vitamin D. Because I just got off the phone before I connected with you. I was on the phone with a pediatric nephrologist in another part of the country who was calling me about a patient. And he said, oh, by the way, the one thing that's been abnormal in his blood work was a 125 vitamin D. And that led us right down the diagnostic pathway. And sure enough, he ended up having a genetic cause for his kidney stone disease. So that's all part of my routine workup from a blood work standpoint. Then yes, from a urine standpoint, of course, I do a routine urinalysis and urine protein to creatinine ratio, but also the 24-hour urine is the most important component in terms of identifying specific risk factors for each patient. So the 24-hour urine is critically important.
And what about patient expectation or parents' expectation with those patients that are stone formers that maybe it's the first time in the family, the parents never had stones, the kid has been passing a lot of stones and they're frustrated because they tried diet, drinking more water. What do you tell those patients?
Yeah, so I go back to the 24-hour urines. The 24-hour urine provides us with the best clues as to how best to prevent stones in an individual patient. I really don't like a shotgun approach to stone prevention, right? So what I'll tell my patients and any trainees who will listen to me talk about stones is that the only things that are true of all stone formers in terms of prevention is that drinking more water is helpful and limiting sodium intake or salt intake is helpful. Beyond that, you really can't make any recommendations without a 24-hour urine to look at individual risk factors. And by the way, I hear a lot of times people say, well, isn't it hard to get 24-hour urines in kids? It's really not. Assuming a kid is potty trained, right? If a kid is younger and not yet potty trained, of course, that's a whole other issue. And on occasion, we will put a kid in the hospital, put a Foley in there and collect a 24-hour urine that way. But I can tell you, I can probably count on one hand the number of times that has been indicated in as far as I was concerned. So beyond that, once a kid is potty trained, they do a really good job doing 24-hour urines. And that's one of the nice things about treating kidney stones and researching kidney stones is that generally parents are really willing to do whatever it takes to get to the best answers because they don't want to see their kid in the emergency department again, writhing in 10 out of 10 pain and vomiting. So it's not a big ask for them to do the 24-hour urine. We have about a 95% success rate getting a good 24-hour urine sample.
And David, how important is having a stone for analysis?
Okay, I'm glad you brought this up because this is what I want to shout from the rooftops to my urology colleagues. It is so important to get a stone. And the type of stone sometimes makes the diagnosis, but certainly helps us figure out what the individual's risk factors might be. So an example, if you get a stone and send it for analysis and it's 100% cysteine, the diagnosis is done for you. I mean, we're still going to do genetic testing because genetics of cystinuria is complicated, but you've made your diagnosis and now I can come up with a treatment plan. And then knowing whether it's a larger component of calcium phosphate versus calcium oxalate also determines how we treat, because urine pH is so important in calcium phosphate stones. So it really is critically useful to know what type of stone that the patient is forming. So I would beg all of my urology colleagues that when you've gone through all the trouble to go fetch a stone, please don't throw it in the trash. Send it for stone analysis to a competent lab, because that information is so helpful.
Good to know. So David, so let's talk about some conditions. Definitely you have the genetics versus the acquired. I mean, you mentioned that depending on the age, the younger the patient is, the more the genetic wise versus older they're acquired. What is it the most that you see in your practice?
Yeah, so what I say is that based on the genetics we're born with, anybody can form a stone under the right or wrong conditions, right? Some people have to work very hard to form a stone, and some people have to work very hard to prevent stones. So depending where you are, the gifts you've been given from your parents' genetics determines whether you have to work really hard to form a stone or not. So I would say that in my adolescent range, it's most often not a genetic cause, but I certainly do see genetic stone formers in teenagers. But they're usually environmental issues like not drinking enough water and eating a diet that's very high in salt, eating a diet that's very low in calcium, right? So that's one thing that seems kind of counterintuitive. We've got all these teenagers forming calcium oxalate and calcium phosphate stones. And one of the risk factors for that is a diet that's too low in calcium. There's pretty good data that suggests that teenagers today or kids in general, are getting less calcium because they've swapped out drinking milk with drinking sugary beverages. And so and then increasing sodium intake too. So I think those are some of the main environmental factors causing the so-called acquired stones.
And in terms of genetics, can you run down some of the conditions that we're looking into?
Yeah, so the OG genetic stone diseases were primary hyperoxaluria, cystinuria, dent disease, and APRT deficiency, which is less common in the United States, more common in Iceland and Europe. But those are the 4 genetic diseases that were originally studied here at Mayo before my time here. There was formed the Rare Kidney Stone Consortium, and those were the 4 diseases that they've studied. But since then, thanks in part to our genetic testing efforts, we've identified a number of other sort of emerging stars in genetic stone disease, including some of the most common ones. I'll give you the top 3 are CYP24A1 disease. So CYP24A1 is a gene that encodes for 24-hydroxylase, which is involved with vitamin D metabolism. And basically what happens to these patients is they have a hypersensitivity to vitamin D and to calcium in their diet. So they tend to be hypercalcemic and hypercalciuric, and they form stones and almost always have cysts in their kidneys as well. So that's a common disease we're seeing more and more. And then the other 2 are both diseases related to phosphate wasting syndromes. So one is a defect in SLC34A3 and the other one is in SLC34A1. So both of these are phosphate transporters in the proximal tubule that nephrologists will geek out about. I would talk about it for hours if someone would let me. But the bottom line is they're both phosphate wasting syndromes that traditionally might cause rickets, but now we're seeing evidence where some patients do not have any bone disease necessarily, but tend to have lots of stones and nephrocalcinosis as well as cysts. So these are sort of the emerging conditions that we're seeing more and more. And then there are a handful of, a dozen others that we're seeing, but just in much rarer cases.
So, you mentioned nephrocalcinosis multiple times. Is that just a symptom or a finding of an underlying condition? And then depending on that condition is how you treat it?
Yeah, so nephrocalcinosis is interesting, and we don't really know why some patients get nephrocalcinosis versus stones, versus discrete stones. So when we talk about urinary stone disease or kidney stones, we're usually referring to calcifications that form in the urinary space, right? So that can mean in the tubule, but as opposed to nephrocalcinosis, where we're talking about calcifications within the renal parenchyma, so actually in the tissue. And we don't really know why some diseases predispose to nephrocalcinosis versus discrete stones, but it does seem that patients with nephrocalcinosis tend to have more severe disease and tend to be at higher risk for progression of chronic kidney disease, meaning their GFR drops over time.
I find that also as urologists, if they don't have discrete stones, even though the cats can say, hey, do you have nephrocalcinosis? Everybody else tells them that you have kidney stones. And because of the back pain is those kidney stones. And I have gone there to the kidneys. I look over, there's nothing concrete that I can take out. So it becomes a challenge with treating those patients. Is it the same on the pediatric population?
It is very similar. So, and talking about pain with, stones that are in the kidneys or nephrocalcinosis, the conventional wisdom is that stones that are just sitting in the kidney should not cause pain, right? It's only that journey from the kidney through the ureter and to the bladder is where there's pain. Where do you stand on that? What are your thoughts on stones that are in the kidneys? Can they cause pain in some patients?
Definitely. I would say if I see a patient and he has a small or she has a small kidney stone, I will say, hey, most likely it's not because of the pain. But if they already tell me, hey, I've gone to multiple urologists, I say, well, let's go and do the ureteroscopy. And sometimes they do improve. So I cannot say that's not true. So I have seen patients that small stones, non-obstructive, cause pain.
Yeah, I would agree with that. I would say my experience is the same, where in general, I do say, I do tell patients that as long as these stones just stay in the kidney, they shouldn't cause pain. And so I start out with that as sort of the conventional wisdom and the default. But then over time, like you, I have seen patients where they, keep complaining of flank pain. They're not passing stones, and eventually they have the stones removed and things get better. And it's hard to refute that evidence, right?
Exactly. And when you do the ureteroscopy, you're there and sometimes you actually see that area was obstructed. Those patients are very grateful because everybody keeps telling them that no. But I probably have seen a lot of them that I say no, and then they probably go to another urologist and they do the procedure and probably they're happy.
Yeah. And, I do believe also, though, that there's another subset of patients where while they're not passing overt visible stones, they have crystalluria, right? So they're forming calcium oxalate crystals, and those crystals themselves, I believe, can cause some pain as they travel down the ureter and even some bleeding. They're super sharp crystals, and they might be nicking up the urothelium and causing some irritation. So it's not usually that, 10 out of 10 drop you to your knees kind of pain, but more of a dull ache. And I tell my patients, I say, if you feel that, that's your warning shot. You got to drink, guzzle some water right away, because you've got to, dilute that urine and wash that away.
And talking about those patients that on the urinalysis they have crystals, does it mean anything if the imaging is normal and they have probably no history of kidney stones or nothing obvious?
Yeah, so I tell them if we do see that, I say that again that this is showing that you have this risk factor, right? So crystals are the beginnings of stones. And so this is your warning. This is your time to take notice and start to do the things you need to do to prevent stones. And so that's on the practical side. But then also sometimes those crystals can help identify what type of stones the patient is at risk for, and sometimes even can be diagnostic, right? So if we see the classic hexagonal cystine crystals, then I'm worried that that's a patient. In fact, I'm nearly positive that that's going to be a patient who's going to have a diagnosis of cystinuria.
And David, let's say a young kid that have kidney stones asymptomatic, and you do the testing, the patient has hyperoxaluria, or a patient that you might treat it with medical treatment, we'll go into that later. Do you prefer that patient to undergo surgery versus medical treatment? How do you decide, or how do you tell the patient, hey, let's try something this first? versus something more aggressive?
I usually leave the decision about surgery up to the urology team, in discussion with the family. I'm going to do what I can do to uncover their risk factors and come up with a prevention strategy. But in terms of the appropriateness of surgery, I do lean heavily on my urology colleagues there. Generally, stones that are asymptomatic, that are just sitting in the kidney, we don't recommend a procedure to get rid of it. But if that stone is growing, sometimes it becomes scary. If you've got all of a sudden your 4 millimeter stone is now a 12 millimeter stone, then that's a little more worrisome. And you worry about, well, what if that does decide to break off and move down the ureter?
Probably the same way. But I guess my question also will be, if that patient that is asymptomatic, is there a cutoff between you saying, hey, we can try this treatment to dissolve a stone versus there's no way that stone will get dissolved?
Yeah, so, in kids, one of the major differences between stone disease in kids versus adults is that, roughly 10% of adults who form stones will form a uric acid stone, whereas uric acid stones are nearly unheard of in normal children. There are some very rare genetic diseases where kids get uric acid stones, but they're very uncommon. And uric acid stones are really the main type of stone that could be amenable to dissolution. Calcium oxalate stones, calcium phosphate stones, as a rule, don't dissolve no matter what you do and no matter what people read on the internet. So really what I worry about, though, is that stone, even if it's not going to dissolve, is it going to be a nidus for more stone formation? And so sometimes that's a compelling reason to have stones removed. If you watch them, over time, and 6 months later, they're 2 millimeters bigger, and 6 months later, they're another 2 millimeters bigger, you think, gosh, maybe this is kind of acting as a nidus for stone formation, and we should take it out for that reason.
And what about infected kidney stones?
So those are bad news. That's actually one of the big take-home points I teach to the trainees, is that if you've got a kid with what looks like renal colic and a fever, that's a true emergency. That's a kid who needs to get to the emergency department quickly, because that can go sideways fast. Sometimes, of course, the stones themselves can harbor bacteria, but if they've got, if the urine behind an obstructive stone is infected, that can spread to urosepsis quickly. So that's definitely an important teaching point for, like I said, the trainees, but also the families, is I make it clear to them, if that happens, if they've got, these symptoms consistent with renal colic and a fever, they need to get to the ER very quickly.
And going back to the conditions, what are some of the possible treatments to prevent stones? And we can just go one by one. Let's talk about first hypercalciuria.
Yeah, so hypercalciuria, obviously one of the most common risk factors for kids with kidney stones. And so, like I said, going back to what is true for all stone formers, more water, less salt. And in hypercalciuria, the reduction in sodium is critically important. So there are very good studies showing that the more salt you eat, the more calcium you put in your urine. The mechanisms aren't exactly clear, but it's really well established. So I spend a lot of time talking to them about sodium, because it's a benign thing to do, right? So, a low sodium diet in adult medicine is considered 2,000 milligrams a day. Well, adults only need about 500 milligrams of sodium per day. So saying 2,000 is being really generous. So I spend a lot of time talking to them about, where to find sodium on a label, where you're getting it. I show them how to look up on the internet, if you eat out, if you're taking your kid to Subway and they've got these 3 favorite sandwiches, here's how you compare the 3 and determine which one would be most appropriate given the sodium content. So the good news is that in the era we live in, the information is out there. There's no excuse for people not to know how much sodium they're eating. And especially for the hypercalciuric patients, it's so important. So if I direct them to drink a lot of water and I give them a specific amount to drink and a strategy on how to achieve that water intake, and we achieve the sodium limitation and they're still forming stones, so then I would consider thiazide diuretic. So I know the thiazide diuretic in calcium stone forming adults is like a go-to, like it's almost automatic. But for kids, I'm a little more reluctant. I want to see that they have failed the water and salt approach first, because number one, nobody wants their kid to be on a medication. So, parents are kind of reluctant to start about starting a medication. They have to use the bathroom more frequently, which during the school day can be disruptive. And then perhaps most importantly, we see more electrolyte disturbances in kids on diuretics than adults. So most commonly hyponatremia and hypokalemia. So the younger the kid is, the more worried I am about an electrolyte disturbance. So, if they failed the sodium and water approach and I start them on a thiazide diuretic, then I will check an electrolyte panel a week or two after starting just to make sure that their electrolytes aren't out of whack. So I will use thiazide diuretics in hypercalciuric patients, but in a little more limited capacity than in the adult world.
And in terms of follow-up for, let's say, hypercalciuria, do you repeat the 24-hour urine collection at some point, or you just go by imaging?
Yeah, so both, depending on the situation. I take a very practical approach, again, understanding that families are usually just fine doing a 24-hour urine, but I also recognize that it is disruptive, so I don't want to do them just to do them. So as you alluded to, I take a pragmatic approach and really follow the imaging. Certainly, if the imaging is showing worsening stone burden, I'll check another 24-hour urine and see if anything has changed. And I'll also check a 24-hour urine if we do make a significant change in their treatment plan. So if I've got a kid who's been hypercalciuric and we start them on a thiazide diuretic, I'm going to want to prove that approach is effective. So I will repeat a 24-hour urine in someone like that who I've made a significant therapeutic intervention. I'll add one more thing about the hypercalciuric patients. I also will consider supplementing potassium citrate, right? So citrate, we know, can help with stone disease in a couple of ways. First of all, the citrate binds up free calcium that's floating around and makes it unavailable for crystalline stone formation. And then the other thing that it does is it alkalinizes the urine. Now, so that's great for calcium oxalate stone formers. Calcium phosphate stone formers, we have to be a little more cautious because calcium phosphate stones form in a more alkaline urine. So if I've got kids naturally have a higher urine pH than adults. So if I've got a kid who's walking around with a urine pH of 6.9 or 7 and is forming calcium phosphate stones, the benefit of adding a citrate supplement is questionable. And so you have to be really careful and thoughtful about that. But certainly in a kid who's forming calcium oxalate stones, has a urine pH of 6.2, potassium citrate is probably a pretty smart choice.
For that calcium phosphate, what do you offer that patient?
Yeah, so calcium phosphate stones, certainly we look for the underlying cause. So calcium phosphate stones are rarer and therefore trigger my suspicion for a genetic cause. And so in the phosphate wasting syndromes that I mentioned previously, this is why the genetic testing is so important, because for those with the SLC34A1 and SLC34A3 gene variants that are causing disease, the treatment of choice for them is a phosphate supplement. And I know it sounds counterintuitive, but I won't go too far into the weeds. But the thing that's driving that is an elevated 125 vitamin D. And when you supplement them with extra phosphate, it suppresses and brings down that 125 vitamin D, which then in turn reduces the hypercalciuria. So there's a great example of why knowing the underlying disease mechanism really directs your successful therapy.
And in those patients that have high elevated vitamin D, how elevated we're talking about?
Yeah, so in those conditions, the 25 vitamin D, which is the one you typically, when people in most clinics are checking a vitamin D level, they're checking a 25 vitamin D. In Stone Clinic, we're checking a 125 dihydroxy vitamin D. And so the elevation that we typically see is not super high. Like in our lab, the upper limit of normal, I think, is 65. And they might be 125, but they might also be 90. So it doesn't have to be super high.
But it's high.
Yes.
Because, I think, in my practice, I see a lot of patients the other way. I see a lot of vitamin D deficiency, even though I'm here in Florida and we have a lot of people coming from all over the states. And even though the sun is there, I have talked about this out with other urologists, that classically we know about the sun, supposedly the source of vitamin D, but every time that we see more patients with low vitamin D, and they say, hey, I'm always outside, but definitely the genetic component is what we're not accounting for.
Yeah, and so we do struggle sometimes with vitamin D supplements in our patients because, believe it or not, in Minnesota, we have a ton of vitamin D deficiency. And I would put air quotes around vitamin D deficiency because I'm a skeptic when it comes to the clinical relevance of some of these milder vitamin D deficiencies that Everyone in America is now taking vitamin D supplements. Of course, I'm exaggerating, but a lot of people are taking vitamin D supplements based on a lab result that says they're deficient. I'm wondering if, our reference intervals that are determining what is deficient are perhaps skewed. A decade ago, it seemed like every journal was packed full of papers showing an association between vitamin D deficiency and every clinical condition known to man. And now, though, more recently, the pendulum's kind of swinging the other way, where studies are showing that there's been, no clinical benefit to supplementing vitamin D. So I think that the truth is somewhere in the middle, that yes, there are definitely patients who are truly vitamin D deficient and who benefit from supplemental vitamin D. But then there are others where it's probably not helping anything and is increasing their risk for stones. So a clinical scenario where we struggle with this for real is in our metabolic bone patients. So I see a lot of patients in conjunction with my bone specialists here at Mayo where they've got, pathological fractures and need calcium and vitamin D. But, oh, by the way, they're also forming kidney stones. So the endocrinologists want more vitamin D. I want less vitamin D. And so, but, like everything, it's a team approach where we say, okay, well, what's the more pressing problem, right? Obviously, fractures are terrible and we don't want people to have fractures. So if somebody's had one stone and maybe has one solitary little stone sitting in a kidney somewhere, but they've had multiple pathological fractures, then by all means, I'm going to yield to my endocrine colleagues and say, yes, go ahead and do your vitamin D therapy and we'll keep an eye on things. If the stone disease becomes more severe and is now trumping the bone disease, well, then we might shift our perspective. But, like everything, it takes a thoughtful individual approach.
Okay, so what about hyperoxaluria?
Yeah, so hyperoxaluria is something I'm super interested in. And when we find hyperoxaluria, we are concerned about usually two different mechanisms. So either a genetic primary hyperoxaluria, where there are three different types, pH 1, 2, and 3, and they're caused by different genetic abnormalities in each of the types that lead to increased endogenous production of oxalate. So the liver is producing oxalate like crazy, and that's ending up in the kidneys and causing stones, nephrocalcinosis, kidney failure. So the genetic primary hyperoxaluria, that's one category, and then the other is enteric hyperoxaluria. So that's where the patient is either eating way too much oxalate, or more commonly in kids, has some condition where they're absorbing more oxalate from the gut than they're supposed to. So, we all absorb a certain amount of oxalate from our normal diet, and for most people, that's fine. But there are certain people who have very clear enteric hyperoxaluria, where the way I prove it, so first of all, the approach is, okay, you've got hyperoxaluria based on a 24-hour urine. The next step, so I will often order what we call at Mayo a hyperoxaluria panel, where it's just on a random urine sample. You send it off to our lab and it looks at the oxalate concentration in the urine, but also 3 different metabolites related to the 3 different types of primary hyperoxaluria. So it can tell you, yes, you've got high oxalate in the urine, and yes, you've got an elevated amount of this particular metabolite that is consistent with type 1 primary hyperoxaluria, let's say. Or if none of those comes back positive, then you say, okay, well, this is likely enteric hyperoxaluria. And what I'll often do there, when I've got motivated parents, and I usually do, what I'll often do to secure the diagnosis of enteric hyperoxaluria is I will advise them on how to do a very strict low oxalate diet. And I'll say, do this low oxalate diet for 2 weeks and then do a 24-hour urine. And let's see if there's a difference. And in some cases, there is a huge difference. It's very clear they've got enteric hyperoxaluria. So from that, we can then say, okay, here's how we're going to approach this from a dietary standpoint. And then the other patient population where we see enteric hyperoxaluria, in the adult world, the classic situation is patients who have undergone bariatric surgery. So really any scenario where you've got fat malabsorption. And the mechanism there is, so when you've got fat malabsorption, you increase the amount of fat that is available in the gut lumen. And calcium preferentially prefers to bind to fat. So the calcium that usually would bind to dietary oxalate, and you would just poop that out, now that calcium is bound to fat, leaving all this free oxalate to be absorbed by the gut. So they absorb all that oxalate, it ends up in the bloodstream, and that ends up in the kidneys. So any patient with diarrhea or malabsorptive syndrome or IBD, cystic fibrosis, all of these patients are at higher risk for enteric hyperoxaluria.
So last week I saw a patient, I think it's the first time that I see this type of stone in the clinic, ammonium urate. She was, I think, 34, 35. Second time with a kidney stone. The first time she passed a stone. But then the second one, I had to do a uteroscopy. But yeah, it was the first time that I have seen the stone. She had a bypass. So we're probably in the process of at some point doing a workup and see what exactly is happening.
Yeah, so those types of stones are rare. Actually, dolphins get them a lot. I was once involved in a project with dolphins getting kidney stones. So dolphins in the wild never get kidney stones, but the U.S. Navy for decades has been employing dolphins for various reasons, and they were getting a lot of kidney stones, and it turns out they have ammonium urate stones. But I don't want to digress too far. Let's get back to humans. So the ammonium urate stones that we see in humans are usually associated with patients who, for one reason or another, have metabolic acidosis. Because so it can be through chronic diarrhea. So chronic diarrhea causes bicarb losses in the stool, and that causes metabolic acidosis, or it could be from other rarer forms of metabolic acidosis. Because what happens is that one of the primary responses to chronic metabolic acidosis is increased ammoniogenesis. So the kidney responds by pumping out all of this ammonia, which is NH3, because the NH3 can grab a free proton that's causing acidosis, turn that into ammonium, NH4, and excrete the protons in the urine that way. So this increased ammoniogenesis, then of course, the downside is that you've got all this substrate for these ammonium urate stones.
So I was going to call her and see if she was taking out a laxative or something like that, if she was doing something different. Because when I saw her back to remove the stent, the report wasn't there. I saw it over the weekend. Well, yeah.
Well, and one of the things you can also look at, so the other thing that can do it is patients who are eating a ton of protein. So eating a lot of protein also causes an acidosis, right? Amino acids are acids. And so when you eat a lot of protein, that leads to, if not a true metabolic acidosis, at least a compensated acidosis where the kidney has to work hard to keep the blood pH normal. And so those patients end up with a lot of ammonium in their urine as well. And so there are subtle things like kind of a next level 24-hour urine analysis. If a trained eye can notice a discrepancy between the amount of protein that someone is ingesting and their ammonium production, and it helps you determine whether you should blame the protein intake or whether there's a separate metabolic acidosis that you should be looking for.
And how about cystinuria?
Yeah, so cystinuria is one of my favorite conditions. It's one of the most severe stone disease conditions. And so what makes cystinuria complicated is the underlying genetics. So unlike most of these conditions we've been talking about, something that's unique about cystinuria is that there are two different genes that can cause it. And so you can have, it's generally thought to be inherited in an autosomal recessive fashion. So you need to have two abnormal genes, but they can be a combination. You can either have two abnormalities in one gene, two abnormalities in another gene, or one in one. So the genetics are complicated. And the other problem with the genetics of cystinuria is that unlike primary hyperoxaluria, where you need genetic testing to secure the diagnosis, you don't really need it in cystinuria traditionally. You just need the presence of the cystine crystals in the urine or a stone that you've tested that's 100% cystine. You've got that, that's pathognomonic, you've got the diagnosis. So we're a little bit more behind in what we know about genotype-phenotype correlation in cystinuria, but we're starting to do more work in that area and we are starting to learn more. But the good news is that there are pretty well-established approaches to treatment for cystinuria. It's complicated and it's very hard to do, but you start with lots of water. So an adult patient, you're going to ask them to drink 4 liters, 5 liters of water. Limit sodium, just like all stone formers, but you want them to be particularly strict. Urinary alkalinization, which is super important. Okay, cystine stones will only form in a more acidic urine. So this is a patient population that you really want to get on a potassium citrate and monitor their urine pH. You want their urine pH to be at least 7.0. I like to get them closer to 7.5. They will not form, well, I shouldn't say that as an absolute, but they are at much lower risk for forming cystine stones if you can really alkalinize their urine. So, and then the fourth thing is limiting animal protein. There's not a ton of great data in humans to show that this is effective. So this is something we sort of speculate should be helpful. But animal protein contains methionine, which is a precursor to cysteine. So we think it probably should be helpful. So I don't strictly limit the protein in my cysteinuric patients, especially in growing children. But I will say, avoid excessive protein intake. Like don't eat steak 3 meals a day, So those are the 4 basic things: water, alkalinization of urine, limit sodium, and limit animal protein. Then beyond that, if that doesn't work, then we can try the medication known as tiopronin or Thiola. So tiopronin is a drug that helps break the bonds and keep cysteine in its more soluble form. So it works. Thiola is great. It is expensive, and sometimes kids will have GI side effects and just not tolerate it well. So that's why I don't automatically start with tiopronin. I take the approach, well, let's see if these other sort of more conservative measures prevent new stone formation. If that works, great. If we need more, then we go to the tiopronin.
And again, going back to when do you decide to take the next step and start the medication? Is it going to be increases stone burden or a patient that was free and then has a small one? Or is it going to be how many interventions they're getting because passing stones? What is it? I mean, I know it's going to be informed consent, but...
Right. It's always shared decision-making, right? But it really is about the stone burden. So, for instance, I always warn patients, if I'm seeing a patient with cystinuria and they've got, 3 small stones in one kidney and 2 small stones in another kidney, I say, you've got 5 stones that could potentially pass. That doesn't mean that if those stones pass, that doesn't mean that we're doing a bad job with our prevention strategy. Those stones aren't my fault. If you form new stones or those stones get bigger, that's my fault. And that means we need to reassess and get more aggressive with our prevention strategy. But so I do lean more heavily on stone burden rather than just stone passage.
Any other stone you want to talk about? Any other condition?
Good question. So I think those are the primary stones that I see and worry about. Again, the calcium oxalate stone formers are the most common. And what makes them trickier is that it's really hard to tease out who might be the genetic stone formers and who are just, idiopathic calcium oxalate stone formers, and whom you can treat them conservatively with just, more water, less salt, and take a conservative approach. But those are the patients that I really like to do genetic testing on because, one of my theories, going back to primary hyperoxaluria. So the third type of primary hyperoxaluria was initially thought to be the least common. It's the most recently, identified from a genetic standpoint, and it seems to be the mildest form. But what I suspect is that I would bet primary hyperoxaluria type 3 might be way more common than we think because it tends to be more mild. These are patients who might not be getting genetic testing because they're just, they didn't pass their first stone until they were an adult, and, maybe they form, a new stone every couple of years or something, and no one's super excited about it. But my bet is if we looked for it, we would find a lot of primary hyperoxaluria type 3.
Yeah, I mean, I think that's what most adult patients have. Just eat a lot of oxalate. And I see that I give them always a list of things that they should avoid, and most of them, they do better.
So I talked about earlier how important it is if you collect a stone through one of your heroic interventions that you send it off to the lab for analysis. But also, if you are talking to the folks in the emergency department, and even if you're not doing an intervention, at least make sure they're sending the patient home with a strainer that they can urinate through so that we can collect a stone that way. Because, I always am sad when I hear the patient say, yeah, we went home from the ER and, a day later, I saw my stone pop out into the toilet and flushed it away. And there's a missed opportunity there.
And David, in terms of nutrition, I mean, you went over a lot of things specifically for alkalizing the urine. Is there something that they can do non-pharmaceutical?
Yeah, so potassium citrate comes in pill form, it comes in liquid form. Sometimes patients prefer not to go that route. So, in the old days, there was always this debate about lemonade and Crystal Light and orange juice and, is it helpful? Does it actually alkalinize the urine? And the data are, I would say, suggestive that those sorts of beverages can be helpful. Now there's newer products on the market. So there's a product called Moonstone that is a citrate supplement that comes in a powder that's very tasty. I've tasted it myself. I've had my kids try it and they like it. And it seems to be helpful in alkalinizing the urine and putting citrate into the urine. So that's a possibility. That's just an over-the-counter. You can, buy it online. Moonstone seems to be helpful. We'll learn more as it gets studied. So it's not yet an FDA-approved product. It's a supplement. Didn't have to necessarily prove safety or efficacy, but it seems to be safe and effective. So that's a really good option, I think, for some patients.
Any other supplements that you recommend?
Not really. There are a lot of products out there, but I can't think of any that have any reasonable claim to being safe or effective, right? There's all like kidney stone away and, all these sort of products out there that are suspicious at best.
Yeah, I mean, sometimes I always see a patient that they took one of those supplements and they dissolved the stone. Was it going to dissolve? So anyway, but sometimes it surprised me.
Yeah, right. So, right, if you've got a uric acid, so uric acid stones are so sensitive to pH. And so it would be conceivable that if somebody bought an over-the-counter, product claiming to alkalinize the urine, maybe it did alkalinize the urine and raise the pH enough to dissolve the stone. I'm not saying it can't be true. I'm just saying there's not enough evidence to support giving it to most patients, especially to children.
And patients that do have, they have a genetic component and they have siblings. What do you recommend those siblings? Assuming that they're asymptomatic, do you do any testing on them?
Yeah, so, as part of our genetic testing protocol, we will, again, if the family is up for it, we will check the siblings and look for it. And we do find asymptomatic stones all the time and nephrocalcinosis. So it's very useful to find. As you can imagine, different families have different perspectives on that. Some really don't want to know and aren't interested in genetic testing and have concerns about genetic testing, whereas others are very eager to find out the answer. And we encourage them because the sooner we can get on a preventive strategy, the better off they'll be in the long term. Can I go back? There is one, you asked about another genetic condition, and I thought of one. So the other one that we treat is dent disease. And I should have included dent disease in my original list of stone-forming diseases. So dent disease is generally inherited in an X-linked fashion. And, only about 25% of patients with dent disease will form stones or nephrocalcinosis, but it's still common enough that, it's on our list and we do test it. It's on our panel for genetic testing. So dent disease is a problem with a chloride absorption. It's abnormal chloride absorption, and ultimately they get hypercalciuria, and that's the mechanism through which they form stones. And so they have some proximal tubular dysfunction. But the hallmark to dent disease, and I don't know how frequently you or your colleagues look at protein in the urine, but if you see a high amount of protein in the urine, that's how dent disease usually first presents. And it's actually not. So most patients, when we think of proteinuria, we're thinking of albumin, but this is not albumin. If you look for a specific type of protein called low molecular weight protein, it's through the roof, like 1,000-fold higher than normal in patients with dent disease. And so we're talking about proteins like we usually check retinol binding protein or beta-2 microglobulin. Those are the two proteins we most commonly look for. And when you find that, you are very likely to have dent disease if that's super high. So those patients can form stones, and we often treat them with a phosphate supplement and sometimes a thiazide diuretic.
And then, David, my last question will be that transition from pediatrics to adult. Because I do see patients that come to the clinic and say, well, usually I don't think I have seen cystinuria. Usually it's hyperoxaluria, and they're probably already on potassium citrate. Is there anything else us as adult urologists look for in those patients?
Yeah, so the transition from pediatric to adulthood in patients who have chronic disease, and by the way, that's what I do consider stone disease to be, a chronic disease, it is always challenging. And so, there are different rules at different institutions about where that cutoff is. Here at Mayo, and I think at a lot of institutions, 18 is that's legally when you become an adult, so it seems like an obvious choice. But we also have the flexibility here to hang on to our patients a little bit longer. And again, it's shared decision making. What's the patient comfortable with? If they're going off to college and they're going to be coming home to mom and dad and living under mom and dad's roof and depending on mom and dad for everything, well, that's still, to me, I'm happy to hang on to those patients for a few years and keep managing them, again, assuming they're comfortable with it. If they're, going off and hitting, graduating from high school, going and getting a job, getting married, having a family, well, then now you've got adult problems. So I try to transition them to the adult side. So yeah, I try to make sure that they are clear about what's important for them, so that they have a clear understanding of how they should prevent stones. And then really, to me, the most important thing is that they have a plan for how frequently they'll get imaging. Depending on the patient, if they've been really well controlled, I might say check in and get an ultrasound in a couple of years. But if their stone disease is much more active, then we might say, okay, I'm going to set you up with an appointment with adult nephrology and or urology with an ultrasound in 6 months or something like that. So it's depends very much on the individual situation and the needs of the patient.
And going back to your MPH, the nutrition, how much time do you dedicate to nutrition with these patients?
Quite a bit. So, probably about half of my time is in a clinic visit is spent talking about, getting a good history, figuring out, so I ask in my first visit, I'll ask very broad questions like, is there anything interesting about your, if it's a teenager, I'll say, is there anything interesting about the way you eat? Like that your friends say, oh, it's weird that you eat this way or that way, to figure out if, they crave salt like crazy, or, they eat rhubarb pie twice a day, something really weird. That can help figure out where they are. I will also ask them, I'll say, would you say that your diet healthier than your friends, not as healthy, or about the same? Just sort of vague questions to help me understand where their diet is. And then if their 24-hour urine or any of their blood work suggests something more significant, then I'll get farther in the weeds and sort of really try to quantify how much calcium they're eating, how much salt they're eating, oxalate, all of these things. And then we'll spend some time talking about, what their diet should look like. And, we have lots of handouts too. Every dietary component that we've mentioned, I've got a handout for it to aid the discussion and send them home with.
And you mentioned at the beginning that you have a theory in terms of why more kids are forming stones. You already mentioned the change of milk versus other like sweet juices or something. Also, does fast food play a thing in this? All the salt in the diet, sodium in the diet?
Yeah, so certainly fast food plays a role, and we love to vilify fast food, and for sure fast food is not healthy and usually contains a ton of salt. But what I would also say is eating out in general, you're going to get way more sodium than you want. If you look at just about any restaurant, if you look at the nutrition information, which they're by law required to make available on the internet, right? Unless it's like a local mom and pop place that just has one or two locations. If it's a restaurant that has multiple locations, they have to put their nutrition information up there. And if you look at it, it is full of salt. I include a slide in my talks about this with the nutrition information from Outback Steakhouse, which is, nobody would consider that fast food, right? Most people would consider that a decent restaurant. And if you look at their sodium content of their appetizers, right? So they've got like 50 different appetizers. Last time I checked, there were only 2 appetizers out of all of them that contained less than 1,000 milligrams of sodium. So it's everywhere. So I do tell families that, listen, if you're really serious about limiting sodium, the only way to truly do it is to eat food that you've prepared at home, fresh foods that you've prepared at home. We also talk about prepackaged foods and how, the sodium is often a preservative used in processed foods. And so you're going to be getting a ton of sodium there. And I really, talk a lot about how it hides in places you might not suspect. An example I'll use is potato chips, right? So if I ask a kid or parents, I say, tell me a food that's high in sodium. 9 times out of 10, they will say either French fries or potato chips. And of course, these are not health foods, right? But if you actually look at the labels on, most a regular, typical bag of potato chips that might come with like a lunch or whatever, typically would have 160 milligrams of sodium, which is not terrible. Now, as an exercise, if you take a container of graham crackers and you look at the sodium content there, a serving of graham crackers, depending on the brand, might have 320 milligrams of sodium. So twice as much sodium as the potato chips. Now, nobody in their right mind, if you said which has more salt, potato chips or graham crackers, would say graham crackers. But that's actually the reality. So it's really about educating the patients and having them take an interest in it and find where the sodium is hiding, because it truly is hiding in many cases. And you might be surprised, where it's coming from in your diet.
Exactly. So David, thanks for being here. Do you want to add something else?
No, I think that's everything. Like I said, I always plug the importance of gathering a stone and setting it for analysis, the importance of a 24-hour urine collection. And if you're not interested, for urologists out there, if they're not in, I get it. Like, not everyone loves to geek out on urine chemistry like I do. But if you're not interested in doing it, then please identify, a nephrologist locally who is interested in it and has some expertise, and let them deal with the 24-hour urine, because it is so crucially important. And don't be afraid to seek out that expertise, and contact me. I field phone calls and emails all the time about interesting stone patients, and I'm always happy to help. And again, don't underestimate the importance of genetic testing as well, especially if you've got a patient who's frustrated and forming recurrent stone former, and you can't seem to figure it out. For sure, I would say that's a good indication for genetic testing.
And are you guys doing telehealth?
Yeah, so it's an ever-changing field, and so yes, we do. The short answer is yes, we do telehealth, but there are some limitations now. But it can't hurt to ask, and certainly as time goes by, depending on where this post-COVID world goes with telehealth, we'd love to help out any way we can.
Well, David, thanks again. Thanks for being BackTable.
Yeah, my pleasure. It's been a privilege to be on here. Appreciate the discussion.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend.
If you have any questions or comments, DM us at _BackTable on Instagram, LinkedIn, or Twitter.
BackTable is hosted by Aditya Bagrodia
and Jose Silva.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles, Nick Shellcross,
and Ness Smith-Savadoff. Design and digital marketing led by Brian Schmitz, with support from
Devontae Delbrun.
Social media and PR by Chi Ding.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening, and see you next week.